Okay, so yesterday when we left off, wow, it's being really, okay, I'm gonna have to do it this way. It's gonna be like, okay, so I was talking about how you can tell if we're achieving analgesia and, posture and attitude and, kind of interaction. And obviously, you look at these patients and they're very comfortable. So the different tops. Now, when we talk about anesthesia, we refer to the periods as preoperative, perioperative, or sometimes intraoperative and postoperative. So when we talk about a pain regimen, usually when we have a procedure, we come up with a pain protocol. And a standard spay, neuter, dental is going to have usually some type of pain medication within the pre-med, which is the preemptive analgesia. So we're kind of pre-treating the pain. And most of the time that's an injectable like butorphanol, buprenorphine is what we use at school, hydromorphone, morphine. Those are like some common pre-meds. I will talk about transdermal fentanyl patches because some patients, fentanyl is a very high power opioid, and it has to be given IV, but it does come in a patch form. The problem when you use fentanyl patches is they take 12 to 24 hours to kick in. You put them on the skin and it's going to be absorbed. But so again, that's not going to be instant pain relief, but it is important if the patient has a patch on, it's going to alter our pre-meds. But it's not like, if you can put one on like at the very beginning of surgery or at the very end of surgery and know that it's going to kick in for at-home pain relief. It's not usually something that we give as a pre-med, but it can't, or you could put it on the day before and it goes on for 24 hours and then they come in for surgery. There's some options, but I do want you to know, like a fentanyl patch takes 12 to 24 hours to take effect. It's not instantaneous. NSAIDs can be used in large animals. So non-steroidals sometimes will be used in that preemptive period before you start surgery. And you can use opioids in large animals. But again, when I get into horses, if you remember when I talked about opioids, is horses are sensitive to opioids. Cats and horses, butorphanol is used a lot in horses because it can give decent pain relief and you don't see the mania that you can see if you use pure opioids. So again, when we talk about horses, that becomes a little more important. And again, in surgery, trying to use multimodal therapy, and all that means is that we're treating pain at different modes or different ways. So like opioids bind to opioid receptors. If you give them an NSAID, like you guys will give the surgery patients an injection of Rimatil, that's a non-steroidal. And those dogs will have gotten butorphanol and they get an NSAID. So you're kind of treating pain at two different pathways, and that's considered multimodal therapy. And again, the goal when we do preemptive analgesia is to reduce the amount of the concurrent drugs and to hopefully reduce our inhalant. And, that's the goal of having a good pre-op and a pain protocol. Now, this is exactly what I said. So multimodal therapy, reducing all the drug doses within a protocol. And so when we think about the patient, we have to cover analgesia at all of these stages. So you have pre-anesthetic period, which again is usually not painful because they've come in and we haven't done anything. But then when we're in surgery, occasionally, sometimes a patient, we'll give them a pre-med, and during surgery, what you'll notice, and if you remember when I talked about inhalants, I said your goal is to try and keep them, at 2%, maybe 2.5%. But if you notice that you have to turn the patient up like 3.5% ISO, because ISO doesn't treat the pain. It just keeps them asleep. It prevents them from reacting. So the more you turn them up, it means they're probably reacting to something during surgery. And maybe, when they tug on the ovaries and when they clamp the ligament, there's certain parts of a spay and a neuter that it's predictable that a patient might react. Now, if they react very temporarily, because sometimes I'll notice every time the doctor clamps when they're doing a castration, I get a little huffing and puffing. And once they cut and ligate, then all of a sudden the panting stops. So it's sometimes there's a minimal reaction, but if you keep having to turn them up and you can never turn them back down, you may want to consider giving something intra-op, giving another dose of butorphanol. Or, so sometimes you have to give intra-op pain meds to continue or to treat pain during surgery. And then a lot of times post-operatively, we want to continue. I mean, when I was at Purdue and we used morphine as our pre-med, and if the dog got morphine at 8 a.m. as a pre-med, we knew that morphine lasted about 4 hours. And so pretty much at noon, we would give that dog another dose of morphine, whether we were in surgery or we were in ICU, and that dog would get morphine every 4 hours. The older thinking was, let's wait and see if the dog is painful. And the problem when you do that is that by the time they show you they're painful, they get into that wind-up stage. And then you're needing much higher dosing. It's better, what we did was we just kept them on an every 4-hour dose of morphine, regardless of what they were showing. And that is kind of what is, and nowadays, they use a lot more CRIs or constant rate infusions. And so those dogs are getting those infusions during surgery. They're getting them post-op for 24 hours. And so they're just getting a constant drip of pain medication. So, post-operatively, you're either sometimes going to dose post-op or you're going to go from 4 hours from your pre-med and potentially start. And while they're in the hospital, they're going to need continued pain relief. At VCA, our protocol is after surgery, they're on their CRI. So usually when they come out of surgery, say at 3 o'clock, and they're on their CRI for overnight. And then when it gets to be in the morning, because, we're 24-hour hospital, when it's between like maybe 2 and 4 a.m., they start to turn the drip down. They start to decrease the drip. But normally what the surgery techs do is they fill the oral medications, maybe the Rimadyl, the Tramadol, the gabapentin. And so at like 6 a.m., when they do the feeding, they usually try to turn off the drip and give the dog his oral medications. And then if he's in the hospital for another day, we would continue to give the oral medication. So it's not like we stop and then send the dog home and then tell the owner to give the meds. We want to try to continue this continuity from the CRI to the other pain medications to when we send them home. And then obviously there's going to be usually some at-home pain relief protocol. In cats, for example, sometimes we send home a buprenorphine. Now buprenorphine, which is an opioid, but remember it's a partial agonist. In cats, it is actually can be given sublingual. And so the owner, and all they have to do is drip it under the tongue. So they don't have to give it sub-Q. You don't even put a needle on it. Make sure you take the needles off. So when we send it home, we pack up these little syringes and we put it in a bottle and we're like, give 1 syringe sublingual every 12 hours for 3 days. So we're continuing. And depending on the surgery, depending on the patient, depending on also the client, what are they willing to do or what can they do, is how we kind of come up with an at-home protocol. So when you think about any drug we can give for pain, we first have to look at how severe and what type of pain. Treatment for a post-op fracture that we send home is going to probably be different than a post-op castration. So depending on the severity of the case, What is the patient's overall condition? Because again, are they nice and happy, healthy? Do they have some kidney disease? And route of delivery, because again, if the owner, or now when we give it in the hospital, we're all very experienced on how to give meds different ways. But any protocol that we do, we also have to know, are we continuing that at home? So what route are we going to give it? So we have talked a little about opioids, but this will be a review, but I'm gonna definitely make some more in-depth comments that they vary in potency and their duration and their effects. Now, if you remember, when I talked to you guys about how to study drugs, when opioids, what do they have in common? And then there's different opioids in that category. Something makes them different from each other. And that's how you have to study, is like what makes morphine different from buprenorphine? What makes fentanyl different from hydromorphone? There are going to be key differences. And sometimes, that kind of it's because of route. And a lot of times it's because of duration. But usually they're used as a pre-med. They're a common pre-med category. Their primary reason is for analgesia. Now, usually most opioids are best when you combine them with a tranquilizer. Ace-promazine, you can do ace morphine. You can do butorphanol dexmedetomidine. I never pre-med a dog with ace and dex. If you remember your categories, you very rarely choose two drugs from the same column. It's like I pick a tranquilizer and I pick an opioid and I sometimes give an anticholinergic. So it's like pick one from column A and one from column B, if you think of it that way. But their goal is to diminish windup. Pre-treat, hopefully we never get to that windup stage. And most of them will last somewhere from 2 to 4 hours. And when you give an opioid and a tranquilizer, you put them in a state of neuroleptal analgesia. And if you look at that word, neurolept is the sedative part, analgesia is the pain part. So neuroleptal analgesia literally is putting them in this sedated pain relief state. Now, most of the time we're using sedative doses. I did say sometimes you can use like midazolam hydromorphone in higher doses and you can get them intubated on a neuroleptal analgesic combo. The only time I use that for an induction agent is if I have a very, very debilitated patient. It doesn't work in your happy, healthy adult patients. You have to have a pretty debilitated animal, and it works better with a pure agonist. So I don't really use that protocol in cats because you have to give such a high dose of hydro. So there's times when you would do that protocol, but most often when you use neuroleptal analgesics, it's in a sedative form and not an induction form. So most of the analgesics are great for post-op analgesia. You can give them alone. Sometimes, post-op, most of the time post-op, you're continuing with the pre-med opioid you used. And then the sedative, most of the time they're sleepy after surgery. The only time we would give them a sedative post-op is if they were kind of crying out, acting out. Sometimes if they're aggressive, we do sedate them post-op because they're being aggressive, and you can actually do that. They do have sedative properties, and they can have some anti-anxiety effects, except cats and horses. So cats and horses usually will have more excitement and what we call dysphoria. Euphoria is when you feel great. Dysphoria would be like, I don't know where I am, I'm crying out. And again, your average horse is upwards of 1,500 pounds. I really don't want to be around a dysphoric horse. They're scary enough when they're awake and they're normal. And then you give them a drug that makes them feel loopy. So again, and in cats, I have used pure opioids like hydro in cats. But when I give them a pure opioid, they always get a really good dose of sedative with it. And we hope that we give enough sedative to counteract the excitement. So like I said, there's going to be situations you can use those stronger opioids in cats, but you just have to be aware of the excitement. The big thing about opioids in general, most of them will increase GI activity when you give it. So you can see nausea, and a lot of times you'll see drooling. You will get vomiting in some patients. So I watch them, especially when they're in their cage sedated, especially when I'm getting ready to induce them, because they can vomit at any stage. And a lot of times they will defecate after pre-med. And a lot of times we'll get them out of the cage and we'll start putting their catheter in, and all of a sudden you smell something. And then you look back there and they've left a nice little present under their tail, because sometimes they just let their bowels go. So it's very common, but what happens is after you get this initial GI stimulation, long-term opioids can actually slow GI activity and cause constipation. In people that are on high-dose long-term opioids, it's a huge problem. It's called opioid-induced constipation. There's actually drugs that treat it. I was watching the Super Bowl one year. I can't remember the name of the drug, but every other commercial was, do you suffer from OIC, which is opioid-induced constipation? And there was a little cartoon intestinal tract following this person. You know, some of these drug commercials are really weird. I literally was like every other commercial. Finally, my son was younger. He's like, what's opioid constipation? And I was just like, okay, am I going to explain this to you right now? But now in dogs, we're not typically on long-term opioids like in people, but if we have like a severe fracture, or we have a patient that is on high-dose opioids and they're in the hospital for multiple days, we do want to monitor bowel habits. And what I want you guys, I always like to stress client education with you. It's a huge part of nursing care. It's a huge part of your job. I always tell owners that they may notice some constipation at home. They may, because probably the number one thing that owners would call when I was working in surgery, they would call and be like, my dog hasn't pooped. And most of the time they call for the tech. The doctor doesn't get the phone call. And the big things I tell them is that, it can be 2 to 3 days, sometimes post-op, before they have a bowel movement. They were NPO'd. They were in the hospital. They're not moving around as much probably after big surgery. But I said, if you get to day 3 and we still haven't had a bowel movement, but the key in constipation, I would always ask them, is your dog outside trying to defecate and cannot? Like if you see them straining to defecate and they're getting nauseous and they're vomiting, because a dog that is truly constipated, if it can't go out one end, it's going to go the other way. So, a dog that needs an enema potentially is nauseous, not eating, and vomiting because they're so backed up that it's going to go the other way. A lot of times these dogs just don't really feel the urge. And I say, put a little pumpkin in their diet, put a little Metamucil, make sure they're getting enough water. And then sure enough, by day 3 or 4, they defecate. I'm like, when they got to go, and the doctor I used to work with, he's like, when they got to go, they'll go. He never was really concerned. But the big thing was, were they showing active signs of trying to defecate and cannot? So I do want to mention that sometimes dogs, and again, this isn't like a 1-dose pre-med kind of thing. These are usually seen in dogs that have maybe been on a CRI longer. Maybe they've been on morphine or hydro in the hospital for multiple days. We do have to watch about ileus and colic in horses because, again, they're hindgut fermenters. So we do have to be cautious because they rely on the hindgut and we could potentially set them up for colic. So that's another reason that we kind of caution these high strength opioids in horses, mostly because of the excitement, but then again, we worry about the colic. Okay. They do have liver metabolism to some degree. So Again, you can use them in a patient that has elevated liver enzymes, but what do I want to do to my dose? If my dog has elevated liver enzymes, how do I adjust the dose if I'm going to use the drug?
You lower it, right?
Yep, because essentially it's going to have a more profound effect, or it's going to last longer. So it's not that you have to completely avoid them, but you might use a lower dose because you can always give more. And remember, some of these opioids are reversible. So if you get into trouble, it is the pure agonist opioids, there is a full antagonist and you can reverse them. So, like I said, probably, I worked at Purdue in anesthesia. I was there 7 years. I saw us reverse a dog only 2 times, and all I did was surgery. So, in that amount of surgeries, and we saw some pretty bad cases, we saw the worst of the worst. So, that kind of tells you, like, it's not common to have to reverse these, because most of the time, the side effects of these drugs, there's not like very bad sedation or very bad respiratory depression. It's usually mild. And so we try at all costs to not reverse. So, um, so if you need to review, um, if we're going to do moderate to severe pain, these are the opioid agonists. And the ones that we need to know are morphine, hydromorphone, and fentanyl. I'm not going to talk about oxymorphone. I think most clinics have gone to hydro. Oxy and hydro are like twins. They almost do essentially the same thing, except hydro is cheaper. When they came out with hydro, I used oxymorphone at Purdue. And then when I got into practice, I noticed we were using this drug called hydromorphone, but it literally did almost the same thing and it was cheaper. So most clinics have transferred, if they're going to carry a pure agonist, a lot of them use hydromorphone. And then some clinics, usually specialty or research, are going to potentially have fentanyl. There's a lot of regular vet clinics that probably won't even carry fentanyl. A lot of regular vet clinics, I'm going to be honest, a lot of general practices don't want to carry these drugs. Why? Why wouldn't we find these drugs in a regular GP
It's a
hospital?
it's a controlled substance.
Yep. These are Schedule 2. They're the highest schedule that we have. There is Schedule 1, but like that's street drugs, cocaine, heroin. We go down from that is these drugs. So the record keeping is stricter. The DEA is going to inspect your clinic regularly, and they have a high abuse potential. So there's some clinics that just don't want to, we don't have these at school. But again, we're not doing very in-depth pain surgeries. And there's going to be a lot of practices that won't care. We have all these at VCA, but again, we have a surgery department, a neurology department. I mean, they're doing craniotomies at VCA, brain surgery. So, I mean, you're doing, depending on the level of surgery your clinic does, when you get into more advanced procedures, you want to have these drugs available. But so let me talk about the differences between them. So these are all Schedule 2s. Morphine, the big thing is this was kind of I call it the OG. Started with morphine. It's dirt cheap. It's cheap, cheap, cheap. And it's been around forever. And it is good for moderate and severe. Now remember, visceral is organ pain, somatic is body pain. Like muscle and bones is considered somatic, and visceral would be deeper pain. It can be used as a pre-anesthetic and it can be used as an analgesic. That's kind of its job. It is a pure agonist, so it will bind. If you remember, and hopefully you save your notes from Anesthesia 1, I gave you that opioid chart that talked about the drug, and then it had the different receptors. So morphine binds to mu and kappa, which causes the euphoria, the pain relief. But again, it can cause dysphoria in cats and horses. Cats and horses, again, the theory to remember is they potentially have more opioid receptors. So when you give a normal dose to a cat and a horse, they're going to bind to more of that drug, cause a more profound effect. But we tend to see this dysphoria in cats and horses, and it can cause some restlessness in dogs. You can give it, what I do want you to know, IM, IV, sub-Q. It can go all routes, but you can give it intra-articular. Articular is the joint. So if you have a dog that it's having stifle surgery, you can inject it into the joint and it'll actually work locally and it'll bind to those receptors, epidural or spinal. And most of the time we're not doing spinals in veterinary medicine. An epidural, so the dura mater is what encloses the spinal cord. Epidural is above that. Spinal would be you are injecting into the dural space. So that the difference in an epidural and a spinal is where you're putting your needle and where you're depositing your drug. So most often, so you can get, now in our next chapter, I'm talking about local anesthesia. Technicians can do epidurals. You guys, if you go into a specialty hospital and you work in surgery, you can be trained to give an epidural. We were trained at Purdue to give epidurals. So that is, and sometimes we would give a morphine epidural, and sometimes we would give morphine and bupivacaine. So it can be used, but I want you to put a note about morphine somewhere, wherever you're writing notes. Morphine has two forms. So there's a preservative and a preservative-free form. If we're doing epidurals or spinals or intra-articular injections, we use preservative-free because we don't want to have a reaction in those spaces to the preservative. And also, when you use preservative-free morphine, it usually comes in a vial that you crack, like a glass, and you're less likely, because in a regular morphine bottle, everybody's injecting into that bottle. It's a multi-dose vial, and everybody's been injecting into that bottle. You're more than likely, there's potentially some, even though there's a preservative in that bottle, there's potentially some contamination. So they'd rather you use the preservative-free version of morphine if you're going to use it for epidurals, articular injections. But if you're using it for a standard IM, IV, sub-Q, then potentially you can go ahead and use the preservative form. Some of the adverse side effects of morphine, and again, the GI stimulation happens with all the pure agonists, and the ileus and colic can happen. You can get some excitement. Now, what happens in dogs, meiosis is where the pupil constricts. Mydriasis, in cats, they look like they have saucers for eyes. They're all pupil. Now, normally, I told you guys, sometimes you do what's called a PLR to assess pupillary light reflex. It's another reflex to monitor. Now, a patient that is anesthetized, they should have a sluggish reflex, and we should see some pupil constriction. If you have a cat under the influence of morphine, you're going to see a whole lot of pupil and sometimes a very delayed pupillary light reflex. That's normal if they had morphine. If their eyes look like that and they didn't get morphine, I would be concerned. So that's kind of a way to explain pupil reaction to certain drugs is going to make them look different. And but if they're dilated and sluggish, that's normal if they got morphine, not normal if they got other drugs. So it can cause, the thing that everybody worries about when they use opioids, and this is going to apply to most of the drugs, they worry about bradycardia. But what I want you to remember, and I try to stress things, and I try to ask things on tests, but these are things that I'm fundamentally stressing that everybody should be able to answer before you go to surgery rotation. I almost feel like if you can't answer this question, you shouldn't go into surgery rotation, but I don't have that power. The only drug that we give that causes severe bradycardia is what?
Dexamethasone.
Yay! Okay, and I'm talking, you guys did radiology rotation. You saw, I mean, you guys did AJ and his heart rate was in like the 40s. Okay, when I say they're bradycardic with morphine, it's not like that. It's not like my heart rate's 30 to 40 beats a minute. But if they had a pre-op heart rate of like 120, they might be like 80, or they might be like 70. You know, it's going to be slower, but there is no other drug category that causes that severe bradycardia. So when I say bradycardia in this, I don't want you guys to get it confused when I talked about bradycardia with dexdomitor. That's a different level of bradycardia. Remember, I told you, if I take a heart rate after a pre-med and my dog's heart rate is 40, the very first thing I look at is, did my dog get an alpha 2? If they didn't, then I'm like, okay, this is concerning. If they got an alpha 2, I'm like, oh, okay. I mean, not like I'm chilling. I'm not like super happy their heart rate's 40, but that's a reasonable explanation for that heart rate. But again, so when this bradycardia is different, and it doesn't cause the vasoconstriction and the high blood pressure, because that's what happens in alpha 2s. That's why the heart rate drops, is because they're hypertensive and they're vasoconstricted. This drug just naturally is cardiodepressant, and it slows down the heart rate. As long as, so again, if it's severe, if you gave this drug, you could give atropine to treat it. Dexdomitor, I don't always give atropine to treat it. It kind of depends. You can see panting. A lot of these dogs kind of messes with the temperature control mechanism in the brain, and panting is kind of a side effect of this. Urinary retention, we're talking like long-term use. If they got it for days and days and days, you kind of need to monitor urine output, but that's not high up there. And I do want to say it can cause some respiratory depression. So their respiratory rate will be slower when they're usually on these drugs. Now, panting is not respiratory depression. That's actually stimulation. And let me mention, I think I've mentioned this to you guys before, a lot of clinics that are using these pure agonists are now giving Cerenia as part of the pre-med to counteract the nausea and to hopefully maybe prevent regurgitation. Again, Cerenia we didn't have it when I was at Purdue because I'm super old, but I believe what I've read from like some of my posts in the anesthesia groups that I'm in is that it's becoming pretty routine to give an injection of Cerenia and then give the opioid, and maybe you won't see that nausea and that potential vomiting. So that's something that's newer. And again, if Cerenia is in a pre-med protocol, it is not an anesthetic, it's an anti-nausea, so it's considered an adjunct. Just kind of like atropine is not an anesthetic, it's sometimes given in a pre-med protocol as an adjunct to pre-treat for bradycardia. Cerenia is an adjunct to pre-treat for anti-nausea. Okay. Let me, I'm gonna skip over oxymorphone and go down to hydromorphone. And this is an opioid agonist. So it's in the same category as morphine. It's a pure agonist, so it's gonna bind to mu and kappa and cause pain relief, euphoria, all the same things that, but it is less potent than oxymorphone, but it is more potent than morphine. And let me explain what potency means. It has a higher affinity for the receptors. So this, when we give hydro, again, think about it. Why would we make two drugs that do the exact same thing? There's obviously a difference. They wouldn't make another drug that does the same thing morphine does and just call it a different name. It has a lot of the same properties as morphine. The difference is this binds better to the receptors, so you can theoretically use a lower dose. So they refined it. It's a better receptor binding, but what comes with that is, I know it says on the slide it's less expensive than oxymorphone. It is more expensive than morphine. If I was going to go cheapest to most expensive, or I should say cheapest to most expensive, morphine's down here. Hydro's going to be right about here. Oxymorphone was up here. And then you got fentanyl up here. But basically, hydromorphone's a little more expensive than morphine, but it has better receptor binding. It can be given IM, IV, sub-Q, so it can be given all routes. And a lot of times it says you can use it alone. Most often it's best combined with the tranquilizer. But let me give you a scenario. When I work the ER, and sometimes, sometimes an animal, like the other day, I was in there with my cat, was not doing well. They brought in this little poodle that for some reason, this was the day that we had the terrible snow. And of course I have to go to the ER with my cat because I should have taken him the day. Anyway, while I'm there with my cat, they come and I look at this poodly thing's back leg is dangling. Like, I'm like, that leg is like barely attached. They were snow blowing and just thought, oh, we'll have our dog outside with us while we're using the snowblower. I'm not even joking. And it got the back legs. Now, one back leg was almost completely severed, and the other leg had some cuts, but thankfully was okay. Immediately, we have no history on this dog, okay? We don't know, and it was in shock because it was just literally like staring, and I'm like, I can't believe this dog is not screaming out in pain. But no, it was just so they immediately gave it a whopping dose of hydromorphone. And a lot of our traumas that come into the ER, especially when they're like if they've been attacked by a dog, and sometimes they come back, and we had a dog that was attacked awfully. I mean, it was terrible. We have to give this dog something. We don't have time to take a history and do blood work and get in, has your dog ever had morphine before? So this drug is very safe. We can give it, A, it's reversible, and B, it's a very potent drug. So sometimes in the ER, a lot of times we get permission. We're like, can we give your dog something for pain? This is before we give them an estimate for like workup and procedures. We're like, we need to give your dog something now. So I just want you to know hydromorphone, because it can be given IV, because it's so potent, because it's a great pain reliever, it is used a lot in the ER as kind of an initial, like before we even touch this dog to do an exam, we have to give it something for pain. And that's where this comes in. And it is a Schedule 2. And I want you to know all the effects that I talked about with morphine. This drug can cause bradycardia, respiratory depression, GI stimulation. Anything that morphine did, this drug can do the same, except this one you can use a lower dose. It's more receptor specific. It's more expensive. And that's kind of the downside to it. Now, let me talk about the last one I'll mention. The pure agonist category is fentanyl. I'm not talking about Demerol either. We use Demerol in people, and I think it's being used now in veterinary medicine, but I want to talk about the more common opioids. It's a Schedule 2, and it's probably the most potent opioid that we have. It's extremely potent, and it'll kick in pretty darn quick. This is the key problem, and I told you guys when you study what are key differences. Fentanyl only lasts about 20 to 30 minutes. It has to be given IV. Well, I will back up. It's a free country. You can give it in the muscle. The problem with giving IM fentanyl is it only will maybe get you an hour in the muscle, maybe not even. And how many of us want to give a dog an IM injection every hour? Not me. So the problem is, because of its duration, this is when I talked about how do we choose a route, how do we choose what drug. This drug, it's best used intravenously. So a lot of animals will be put on what's called a fentanyl CRI, or you can give a bolus of fentanyl IV. But the problem is, again, if you give it IV, you're only getting 20 to 30 minutes. If you want to just give one dose real quick, but a lot of times when we treat pain, we want something that's going to last longer. Fentanyl, unless you're giving it in a CRI, continuous drip, it's great for pain, it just doesn't last very long. And it's probably the most, if there's an opioid that is the worst respiratory depressant, this is it. Now, a lot of people talk about, and if you talk about street drugs, and the problem is that a lot of street drugs that people take had been laced with fentanyl, and these people were overdosing and dying. And I'm going to tell you, probably the main reason, if they didn't choke on vomit because they were sedate and they probably couldn't move themselves, but it's probably from the respiratory depression and they stopped breathing. So what's scary about drugs is sometimes people buy drugs and they think they're buying just this drug. If it's laced with fentanyl, it increases the, people are like, ooh, they're going to like my drugs because they got really high. But the problem is fentanyl is so potent, and it's gonna potentially bradycardia, potentially stop breathing. So if you've heard of it in the news, well, fentanyl is used a lot in people, but then obviously people are making or getting illegal fentanyl and putting it in drugs. And the problem is people don't know that. And then, so when we use fentanyl, the big thing I worry about is respiratory depression. If I have an animal on fentanyl, I need to watch their respiratory rate and their respiratory effort very closely, because it's more potent, so that effect is potentiated. It's going to be a little bit stronger. And what I want you to know, sorry, I'm trying to check the time. Okay, we gotta go. You can give it IV, and I'm going to talk about fentanyl patches a little bit later in it, because there's some key client ed instructions with that. So, whoa. Okay, I'm back.